Yeah,
Perfect.
perfect. Okay, so thanks everyone for coming to listen to my talk today. So I'm going to be speaking about work that I did as part of my PhD in Cambridge, which is about polygenic risk scores and whether they're fair for use in cardiovascular disease risk prediction. So I'll get straight into it. And for those of you perhaps who aren't so aware with cardiovascular disease and why risk prediction is especially important in the cardiovascular disease setting. Cardiovascular disease is actually the leading cause of morbidity and mortality worldwide, and it is especially interesting because it is very preventable a lot of the time. And it's estimated that actually around 70% of cardiovascular disease events are actually due to risk factors that are modifiable, for example, lifestyle factors. And so, why cardiovascular disease is especially interesting from a risk prediction perspective is because it can potentially be prevented. So, we can make predictions about people's risk, and then this can be acted on over time by changing lifestyle and these kind of things, or by getting medication. And this means that the disease can actually often be prevented. And so, it's very clinically relevant to be able to have risk prediction models that can perform well for cardiovascular disease. And of course, this also means that whether they can perform well for all populations, which is something that we'll get into. But the existing prediction models that are used in the clinic, for example, in the UK, there is Q-risk 3, and they're generally very good at identifying individuals which are at very high risk of developing cardiovascular disease in the future. But they do leave many people in an intermediate risk category, which is a little bit of a grey zone, which I'll talk about why we're interested in this intermediate risk population in particular. But this can have a big impact when it's used on a large population-wide scale, as there's so many individuals that are impacted. And so back to the intermediate risk. So this kind of 5 to 10% 10-year risk range is what is classified as medium risk by Q-risk 3, for example. And for this range of people, there's not really any clear treatment recommendations. So perhaps they will go into the high risk category, perhaps they won't, maybe they'll reduce their risk. And typically, these individuals are dealt with through shared decision making with both the patient and the clinician. But this can have quite a high subjectivity, and there's not really clear, actionable guidance for these patients or for clinicians for how to deal with these patients. But there is also a genetic part of cardiovascular disease risk, and this can often be hidden in traditional risk prediction models. The genetic risk is not truly considered, and so polygenic risk scores are one way we can help with this, and I'll talk a little bit about these next. So polygenic risk scores, what they do, if for those who are not aware, is they actually use genome-wide association studies and look at thousands of variants from these and aggregate these into one single value, which is polygenic risk of an individual. And actually, cardiovascular disease is estimated to be around 50% heritable. So polygenic risk scores are very relevant to the cardiovascular disease setting. And what they can do is allow individuals who are perhaps younger or missed by traditional models because they don't have all of the traditional risk factors for cardiovascular disease, but they could have an underlying genetic risk that is quite high. And so there's a strong argument for including these in cardiovascular disease prediction. And it has been shown so far in the literature that there is promise in being able to improve risk stratification when incorporating these polygenic risk scores in combination with traditional risk factors. Um, and so this work that I've done is building on this, which has been identified in clinical consensus statements as a key aspect of a way in which we could use polygenic risk scores. However, there are some controversies regarding polygenic risk scores and their use. In particular, it's related to their transferability across different ancestries. So many of these scores are built using GWAS that is very European centric, predominantly people of European ancestry. And so this means that they don't necessarily transfer as well across different ancestry populations. And so then we have this fear that actually including polygenic risk scores could worsen health inequities, which of course is not what we want at all. And so this study was really to investigate whether including polygenic risk scores could increase or how disparities or how it would affect disparities. And we did this using algorithmic fairness metrics to be able to measure this in a quantitative way. And so I'll speak a little bit about these algorithmic fairness metrics that we used later in the talk. And so really the first question that I'm addressing in this talk is, does incorporating polygenic risk scores into CVD risk prediction worsen fairness across key demographic groups? And that's really the key question that we're hoping to answer as part of this study. And so now I'll like to speak a bit about how we actually did this. So to start with the data that we used, so we used UK Biobank for this because it has a very long follow-up time and it's a large data set, although it's not ideal for reasons such as it is not very diverse as we would like. And so what we did is we excluded people who already had cardiovascular disease at their baseline measurement because the risk prediction tools are built for people who don't already have cardiovascular disease, and also those who are age over 70 because the tools are built for those aged under 70. And of course, we had to exclude people who don't have genomic data because we wanted to calculate polygenic risk scores. And so this left us with 327,923 participants. And then the outcome that we were looking at was whether people had cardiovascular disease within a 10-year period. So this could be a fatal or a non-fatal cardiovascular disease event was specifically what we looked at. And we built this study using the UK recommended QRisk 3 as the baseline. And we recalibrated this for sex groups, and then the risk categories that we used were as follows: less than 5% means somebody is of a low risk, 5 to 10 is medium risk, and over 10% is high risk. And so we use these as cutoffs to determine whether somebody is predicted to have a cardiovascular disease event. So if somebody is above the 10% risk threshold, we can say it's likely that this person would have a cardiovascular disease event in the next 10 years. And also as part of the study, we used inverse probability censoring weighting to handle censored individuals, which wasn't too many, only around 3%. And this allowed us to generate weighted fairness metrics. And I'll speak a little bit about how we did that. And we also used bootstrapping to be able to generate confidence intervals for all of our results. And so, yeah, so in the study, the groups that we actually analysed for fairness were characteristics that are protected by law in the UK. So, and that we actually had enough data to be able to identify groups. So this was age, which was in 10-year age groups, and then male or female sex, self-reported ethnicity, which could not be as coarse as we would like it to be because of data restrictions. So this was in 4 groups that we looked at it. And then also we looked at deprivation using the index of multiple deprivation, as this it does have a relationship with cardiovascular disease prevalence and is relevant to policy in this area. And so then in terms of the polygenic risk scores that we studied. We used for the primary analysis this meta-GRS score, which is well validated, and that's why we chose it. It's been shown to perform well in various validation studies, and there's also no overlap with the test cohort. So this score wasn't built using any individuals who we tested the results on. And we also did look at a few other polygenic scores and for a sensitivity analysis to see whether the results were comparable, and they are overall quite similar. So the choice of score at the moment was not so impactful. And then we actually looked at three different ways you can normalize these scores, which are typically done to deal with um, different distributions in different ancestry groups. And so we looked at these are popular normalization methods that are used, and we looked at the most similar population. And what this does is we identify a reference population for each individual that has the most similar genetic ancestry. And then we adjust the polygenic risk score based on the distribution of polygenic scores within the reference group. We also had N1 normalization, which means that each group is centered to mean zero in the PCA space. And then the second normalization was normalizing mean to zero and standard deviation to one. And I'll speak a little bit more about our results and everything in a moment, but now I'd like to kind of jump back because there's a lot of information that we're bringing together in this. A little bit now about the algorithmic fairness metrics and which ones we chose for this study. So this is taking a bit of a zoom out, and perhaps you're in this audience quite aware of fairness, but one way in which it can be defined is to ensure that an algorithm doesn't benefit some individuals at the expense of others. And we can address this quantifiably using algorithmic fairness metrics. And algorithmic fairness metrics, as I say, can be used to quantify fairness. And we calculate them by looking at different types of prediction differences just in different subgroups and then calculate various statistics on these. But it's not always clear which fairness metric should be used for which context, and there is a very wide variety of them. So for example, one popular metric is demographic parity. And what this says is that for each group, the rate of true cases should be the same. So in this context, we could say for males and females, we should predict that the number of cardiovascular disease events is the same. But this doesn't work in this setting because there actually are differences in the number of events that we see in males versus females, in that males have more cardiovascular disease events. So this is an example of a metric that is very popular and useful in some settings, but not here. So the metrics that we chose, actually, they focus on false negatives because these are individuals that are actually high risk, but that are predicted to not be high risk. So this in the real world setting, if we don't identify these individuals, then it means that they are not prioritized for preventative treatment, and then it's actually causing avoidable harm. So that's why the false negatives are very important here. But still, there's not one correct metric, and so there's different trade-offs between each of them. So next I'm going to talk about the metrics that we chose and why. So we looked at the accuracy equality difference. Sorry, this is a confusion matrix. Just I'm not sure how aware people are of this, but it just looks at the actual high risk, so the observed events that we see, and then what the algorithm predicts on the y-axis to have true positives, false negatives, true negatives. And so all of the metrics are just calculated using this. So accuracy equality difference, what that does is look at the difference in the correctness or the accuracy of the predictions between each group. So we'd say for males and females, for example, the the number of correct predictions is the same for both. And then we have equal opportunity difference, which looks at the difference in the false negative rate only between two groups and the difference between them. And then the conditional use accuracy equality difference looks at the difference in the positive predicted value and the negative predicted value. And treatment equality looks at the difference in the ratio of false negatives to false positives between groups. And so the way that we actually use these in this study is that we can pick a model or a risk factor and then split population into groups that we're interested in. So the demographic groups that I spoke about previously. And the model could be, say, Q-risk 3, or it could be Q-risk 3 plus polygenic scores, which is what I'll speak about. But it can also be risk factors. So we can use this same framework to look at whether risk factors such as polygenic scores or cholesterol, blood pressure, these kind of risk factors, how we can assess those for fairness using this too. And then the third step is to make predictions using the model of the risk factor for each group. So if someone's predicted high risk, then we say they're predicted to have a cardiovascular disease event, and that's the cutoff. If they're not high risk, then they're predicted not to have it. And that's how we generate the confusion matrix, because we look at the comparison of what actually happens to them within the 10 years. And then, yeah, that's step 4. We compare the predictions to the outcomes, and then we can calculate the fairness metrics. So with all of that background and information about how we did it, hopefully that made sense to you. And now I'll talk about the actual questions that we addressed, and there's 2 of these. So the first part is about polygenic risk scores as a single risk factor. So although they're not proposed to be used on their own for risk stratification, we thought it's important to see how their fairness alone looks, and also how it compares to existing traditional risk factors. So whether there are certain risk factors that are more fair than others across groups, and also whether current risk thresholds that are used for the other characteristics, yeah, if they're fair. And so, yeah, this is basically what I just said. And so we wanted to compare polygenic risk scores to that. So firstly, before we actually did this analysis, we wanted to make sure that there wasn't, the results that we got weren't confounded by differences that we see in each group. So for example, if in one ethnicity group, there's a very different age distribution of the people, then we wanted to make sure that if we saw elevated risk in that group, it's not because the age distribution is different. So what we did in order to combat this was a matching procedure. So for each individual, we found their nearest neighbor in a different population, so the most similar person outside of their group, to be able to create matched groups for each. And so what this does is it balances the subgroups on the other characteristics to make sure that, or to try and make sure that they're not confounded by them. And so this means that the differences that we see, the fairness differences, should reflect the actual behavior of the risk factors rather than the population structure. And so this plot here is just to show the matching procedure. So the scatter points are basically how different the mean of each group was before being matched. So we can see, for example, the age is quite different across ethnicity groups. But then the box plots are when we've matched the groups, how those means then compare. So we can see that it's almost 0 in all of the groups. So we can say that this worked effectively. But now getting on to finally some of the actual fairness results that we've seen. So I'm going to introduce it a little bit gradually because I think there's quite a lot of information. So in general, for the metrics, we can say that if there's larger value, then it means there's more unfairness because I have a greater difference between groups of this metric. So for example, one metric we look at is the accuracy equality difference, and we can look at this across the risk factors that we're interested in. So in this case, we chose systolic blood pressure, two different cholesterol measurements, and then age and polygenic risk scores. And so these results here are looking at, for ethnicity groups, how what the differences are in this metric across different thresholds. So this is the top threshold, top percentile for each of these groups. So we looked at 2%, 5%, 10%, 20%, and then in addition to that, any thresholds that are already used in the clinic. So that's why we see these values at higher percentiles for with the triangles here, because these actually capture a very large proportion of the population, yet they are considered to be high risk. So that's also kind of interesting. I'll talk a bit more about that as well. But basically, from this plot here, we can see the polygenic risk scores are quite comparable to the other metrics. Specifically, if we look at cholesterol, we see that the polygenic risk scores over on the right are very comparable. And actually, we see even some higher values, especially on the confidence intervals for the clinical thresholds, especially the non-HDL cholesterol. This is like the first look at some of the results for ethnicity groups, which is what we're very interested in when we're looking at polygenic risk scores. I'm just going to have some water. So now I'm going to introduce some more results for more of the fairness metrics. So this is a plot that we've got for the ethnicity characteristic across all of the different fairness metrics. So it's just like a continuation of what I just showed on the previous slide. And so we see that overall the polygenic risk scores are not really higher in terms of the fairness values than the risk factors that I'd already used clinically. And so there's not really overall from this any risk factor that is more fair overall than others, and it seems like it depends on the fairness metric that we're looking at and the threshold and the risk factor. So this is perhaps surprising, perhaps reassuring, that we don't see a very big difference between the polygenic risk scores compared to traditional risk factors. And this kind of, challenges the perceptions that polygenic risk scores are more unfair and provides some evidence for supporting polygenic risk score use, as of course these risk factors, the other ones, are already used in the clinic. And we do see more variation at the extreme thresholds. For example, down here, we see, I don't know if you can see my cursor, I hope so. And the treatment equality difference for polygenic risk scores, we see a very high value. And I will also note that the treatment equality difference is a little bit more difficult to interpret. So all of the other metrics range from 0 to 1. But the treatment equality difference, because it's a ratio, means that we see much higher values, and that is expected. So it's kind of needs to be interpreted separately to the others in that they're not directly comparable. But so we have all these results here, but what do the values actually mean? Like, is this fair or not fair? We can see that if they're ranging from 0 to 1, these values are definitely on the lower end of that scale, which is reassuring. But we tried to actually understand a bit more about this because there's not really a threshold that is used consistently to say whether something is fair or not fair. And we were thinking that perhaps some of these results that we saw were actually due to underlying variance within the data rather than actual unfairness. So we ran some simulations to be able to understand this a bit more. And so we generated a theoretical model to be able to understand how the risk factors associate with disease in the different um, groups, the different characteristics. So what we did was we varied both the population incidence and the risk factor effect size and the distribution of this in the different groups in the simulation. And then we simulated populations which have the same or different proportions of variation explained by a risk factor. And this helped us to try and understand how our metrics actually behave when we vary this in terms of the incidence and the risk factor effect size and distribution. And so then results for this in the context of what we saw previously is that it's actually for very small sample sizes, it's hard to reliably detect unfairness because there is a greater variation within because of the sampling. And this is something that I think makes sense. But the slope of the trends that we see across the percentiles, like, as in the previous plot, it does seem like it's related to real unfairness. And actually, to see the larger fairness values or unfairness, we would likely need to have a shift in the mean biomarker values and also a different effect size. So it means that there is actually some difference within the groups. And so this actually helped us to derive some cutoffs that we could consider to be unfair. And this is applicable for all the metrics other than treatment equality difference. And so looking at what we see for the simulations, that if it's above 0.05, then this suggests that there probably is some unfairness or some difference that is true across the groups. And if it's above 0.1%, it means that this is likely to be real unfairness, as it's unlikely that it would be observed if the risk factors were identical. And one threshold that is used in literature is 0.2%, or no, 2% or 0.2. And this is related to the US law, and this would mean a very significant amount of unfairness in the context that we're looking for here, based on our simulation. So this is not saying that these thresholds would be true in other situations. And as I said, the treatment equality difference is a little bit hard to interpret though. And the inflation that we see in the tails is probably due to the fact that it's a ratio and we only actually see big differences when there's shifts in the distribution of the risk factor values. And now I'll actually show our results again then in the context of these thresholds and what then we can look at in a bit more detail what it might mean. So we see that there are confidence intervals that extend above a cutoff that we say even of the more conservative one above 0.1, but there's not so many where the mean is above that. But we do see this for equal opportunity difference for the cholesterol, the non-HDL cholesterol. And so this is especially true at the existing clinical threshold. And this is quite interesting as it means that there is some real difference between groups. And this is ethnicity again. And from this, we can also see that actually looking at the different normalization versions of the polygenic risk scores, that normalization does impact the fairness. And so having the normalization does not make something fair automatically. And actually the most similar population is a bit more stable. And then we see the N1 version is unstable here at this low percentile, but then is more stable throughout. And then we see some increased unfairness for the normalization too, up here, especially for accuracy equality difference. And so we can see that the risk factors that are above this threshold, we can say there probably is some real differences between groups here. But we also looked at not only ethnicity, but also the other characteristics of interest. So, for example, for sex, we see that there is some unfairness clearly for the total cholesterol to HDL ratio. And this is especially in the accuracy equality difference and equal opportunity difference, and for both the clinical threshold as well. And so this is interesting, and we think that it's especially like we don't see this when it comes to the non-HDL. So the patterns for the two different cholesterol measurements are quite different. And we think this could be related to in menopause, the lipid profile tends to change in women. And so it could be that one of these cholesterol measurements it is more or less relevant. And so this is something that could be investigated further. And we do also see the current clinical threshold for blood pressure, systolic blood pressure being above this fairness threshold as well, according to the accuracy equality difference. But I mean, throughout this, we can see that the trends for each of the metrics, the fairness metrics, are not the same. And so we can't necessarily say that it's true overall. It depends on which metric we're looking at, which of course is context dependent, as we mentioned before. And so these are all potentially relevant, but it's not like they all say exactly the same thing, which makes it a bit more difficult to interpret. And that is something that is well documented within fairness literature, of course. And then the age results, we see again some unfairness for the systolic blood pressures, especially at the higher threshold, which includes the current clinical threshold. But we see a bit of a contrasting pattern to what we saw for sex in that there is an increase for when you're looking at equal opportunity difference as we increase the percentiles, and this is true also for the current clinical threshold. It's kind of on the edge, but we see actually a decrease when we look at accuracy equality difference, and so it shows that the behavior in age and sex groups is quite different. And therefore that the fairness metric that we're looking at, we can't say that it's true for all like characteristics. So age, sex, deprivation, ethnicity do all show different patterns. So we can't reliably use one to look at all of them. But when we come finally to the IMD results, which is for deprivation, we actually see extremely low values, which is good and perhaps is what we would expect, as we wouldn't expect there to be big differences in the fairness of these. And so, yeah, as I mentioned, just quickly to summarize this part, there's not really one risk factor that is more unfair overall, and the patterns are different for each of the groups and metrics. But from these results, we can say that the polygenic risk scores are potentially likely safe for inclusion, as we don't see any hugely inflated values for these compared to other risk factors. So back to the clinical setting, which was looking at these intermediate risk patients. And this is where we can use the polygenic risk scores in conjunction with risk prediction models that are already used. And so we propose a two-stage risk stratification model to be able to incorporate these. So firstly, we can identify who is at medium risk, and this can be done using a risk prediction model that already exists, such as QRisk3, which is recommended in the UK. And then for these medium risk patients, we then only calculate their polygenic risk score as they're the population of interest. And then we can actually look at a specific threshold of percentile of high risk. And then if they're in this top percentile, then we can reclassify people as being high risk from this medium population. And so the results for when we do this, so we see that the sensitivity is obviously these are not the fairness results. These are just performance results. So looking at the prediction performance, we see as the threshold increases, there is a very notable increase in sensitivity. And this is, if we look at, for example, the 10% threshold, this is around an increase of 5%, which means there's about 924 additional cases in this cohort that are identified correctly. So this shows that there's value to this. But of course, we do see a small drop or a drop in this specificity and accuracy as there is a trade-off because we're having fewer true negatives as we are up classifying more people. But this is a reasonable trade-off as it means that we can actually identify more high-risk patients, and we see an almost constant precision across all the thresholds. But you might notice on this plot that we have the equal number of Q risk as well, which is in the blue color. And this is just to compare whether if we are we seeing these results just because we up classify more people, and so therefore, of course, there's going to be an increase in the sensitivity. So this was to compare if we just took the equal number of people from Q risk predictions and up classified those, or do we see the same? And we do see a further benefit for the PRS use, which shows that it is really finding some additional information and it's not just up classifying more individuals, but it does add value. And although the numbers don't seem huge here, if you think about this on a population scale, it could be really quite impactful. And so then, of course, we're interested in following a similar procedure to before to understand the fairness of how integrating these polygenic risk scores impacts their fairness. So we see, firstly, this is again a similar plot, but this is looking at the change in fairness between the one-stage model, so just a standard Q-risk model, and then a two-stage model incorporating the polygenic risk scores. So it's in comparison to a model that already exists. And so to go through it bit by bit, we see some small-ish increases in accuracy equality difference, which means that there is some more unfairness. This is more pronounced for sex and age, but we see that this would actually be even further when we compare it to the equal number from Q risk. And then for the equal opportunity difference here on the third row, we see that there is clearly an ethnicity increase, especially at the higher thresholds. But for the sex and age, the fairness is actually improved for the PRS version. And then coming down to the treatment equality difference, there is very clearly a decrease, especially notable for the age groups, but also in ethnicity and sex. As the percentile increases, we do see an improvement in fairness there, which is related to the false negative to false positive ratio being more balanced. Whereas for the equal opportunity difference, because that looks at the false negative rate differences, this is what increases or decreases that metric. And then we don't see minimal change in the others. So what does this mean? I think overall we can say that the values are not so high, and I'll talk a bit more about it. And so it's not, we can kind of say it's not consistently more fair or unfair overall again, and actually there's not any really notable scary things appearing here. So perhaps the fairness disparities overall are not really increased, and it's a relatively strong case for these polygenic risk scores being okay to include in these models and not hugely like increasing any fairness disparities. And so then when what to just check, going back to whether this applies, it's just some sensitivity analyses that we did here. There's kind of a lot on this slide, but on the left-hand side, we've got for the single risk factor analysis, how different polygenic risk scores compare, um, and then also their normalization versions. And we see a similar pattern really through all of them, and so they're relatively comparable. And then on the right, we have the two-stage model analysis, and this is just for looking at the one polygenic score, but how the normalization impacts it, because, sorry, on this slide here, we choose only normalization version 1 of the polygenic risk score, just for simplicity, because there's too many things to plot. But then we see on this plot on the right that there's very few differences between the normalization versions, which is quite good, because it means that they all work similarly. And then on the bottom side, we have the same for the different polygenic scores and different normalizations for the performance of the models. And again, it's comparable. So I'm coming to the end, but to kind of summarize some of the implications of this work, it seems that although, of course, polygenic risk scores are not going to solve everything and find everybody's cardiovascular case, it means that they're probably also not ethically dangerous if they're integrated in a thoughtful way, for example, by doing some of this fairness analysis. And it's quite clear, as we've seen, that actually the threshold choice impacts the fairness quite a bit. And so this is something that should also be considered. And this is true also for the standalone risk factors that we looked at, such as cholesterol and blood pressure, where the thresholds that are incorporating a large proportion of the population actually might not be the most fair. And then we can say overall that if we include polygenic risk scores in the risk models, then there are more cases detected, and so we can therefore hopefully prevent more cardiovascular disease. But in general, I'd like to say that I think that this kind of fairness analysis, although it's a little bit difficult to interpret as there's so many patterns and it's hard to make one overall generalization, I do think that this is something that should be included as an evaluation of prediction models in general, to just understand a bit more about how they're working and how this impacts different groups. And so the approach that I've suggested is actually relevant also to other risk factors and diseases, and so it's just a general approach. I'll skip the summary. I've kind of just said that. There's a few limitations though, which of course we have to acknowledge. So UK Biobank, which I used for this, is not representative of the population and it's not diverse. But it provided us with all of the data and the follow-up and the genetic information, etc., that we needed. And so that's why we chose it for this study. But of course, it would be great to duplicate this analysis elsewhere. And there's some other limitations, such as the group fairness. It doesn't capture all of the different intersections of different groups, and nor does it capture all of the socioeconomic determinants of health, etc. And so this was, again, quite limited based on the data that we had. But of course, the analysis could be repeated for different intersectional groups as well. The fairness metrics also don't all align with each other, as I said, so it's a little bit difficult to interpret. And also we assume that the outcome doesn't change based on we're not including anyone's medication, or that how this might impact their outcome. So in the future, this can be replicated in other cohorts, as I said, and also it would be great to look at this analysis using more modern polygenic risk scores. So the one that we chose was because it's very well validated, but it does use mainly European ancestry. So actually this might be overestimating the unfairness, and the newer scores could actually show fewer disparities because they're trained on more multi-ancestry populations and use better methods. And of course, it would be great if this kind of two-stage model was actually looked at in some implementation trials if we're um, recommending this, of course, and the fairness assessment in general should be included in model development, as I said. I've kind of got a lot of summarization here, but yeah, polygenic risk scores, are they fair for cardiovascular disease risk prediction? Of course, we can't say yes, 100%, but when they're used thoughtfully and carefully, we can actually improve high risk patient identification, and they don't clearly hugely discriminate against any certain demographic subgroups and don't really worsen the fairness overall. So that was a lot of talking from me, but I'm done now. Thank goodness for you. No, I'd just like to say thanks, of course, for the Data Science for Health Equity for inviting me, and also especially to my co-authors of this paper, which is a preprint that's also available. And thanks to Cambridge, from where I completed this work, and my funders as well for this project. But now I'd like to invite any questions or comments that you might have.
Thank you so much, Claire. That was a great talk. It's really reassuring that we can still use these polygenic risk scores, given that they're still quite widely used, I guess, in clinical
Uh,
settings.
I mean, then a lot of the time they're not really used yet in the clinic. So this is like part of this work is, I mean, they are starting to be recommended, but there's still a lot of unknowns, and so that was part of this to identify what those unknowns might be, and linking this idea of algorithmic fairness and bringing it in, because there's a lot spoken about the uncertainty and potential inequities, but they haven't been looked at very much in this kind of framework. So that's why we looked at it. Yeah.
Think we had one question in the chat. So,
Yeah, I
someone
can't see the
asked,
chat.
is socioeconomic factors, were they included in your research? I guess probably not in the polygenic risk scores, but maybe in is it the Q3 risk model?
So yeah, so Q risk does include some. Um, so this is, for example, the it takes people's postcode, and that uses like a deprivation thing. But of course that doesn't encapsulate all socioeconomic factors at all. And so that's why one of the reasons why we looked at the deprivation, but we didn't see very big differences, which I think is good. But there's so many different ways in which it could be incorporated. So I mean, we tried to an extent, but like it's very complicated. Yeah.
I see, Farron, you have your hand up. Would you like to go ahead?
Yeah, thank you. So thank you very much for this talk. And I don't want to be picking, but just comment on the first limitation, if I may.
Of course.
So because you use the UK Biobank, but you use this balance design where you match like people by demographics and so on. So that sort of adjusted a bit. But did you consider like weighting the data, weighting the sample so that it would account for the UK rather than being the UK Biobank or something like that to make it
Yeah.
representative of UK?
Yeah. So I mean, when I first started this analysis, these weightings weren't out, and so that's really a main reason why it wasn't incorporated. And so there's a chance that we definitely could, but yeah, that's basically the main reason why we didn't do it. But we've definitely thought about that since, and whether it could be beneficial to include this. Um, I think some of the results, yeah, we can't say for sure that it is or is not representative because of that, but it's like a first way to bring these framework to this field and everything. And so, yeah, perhaps it is or is not representative, but it's something we have considered. So maybe it's something we can do. And it'd be great to replicate it in other cohorts as well, even more, I think.
Sure. Thank you.
You're welcome.
Really?
I think there was some questions in the chat, so I'll defer to that first, and then I can ask mine.
All right. So the first one is, did your analysis account for those in the population who underwent medical intervention to reduce risk, either prior to or during the risk exposure window?
Yeah, so that's one of the limitations, which I mean I went a little bit quickly over those at the end, but basically no. I mean, so the we didn't include any individuals that already had cardiovascular disease. I mean, I don't know, and so that included if they were on statins already. So they, if that is what this individual is talking about, then we didn't include those to start with, but we didn't account for that during the study. So that's also potentially a limitation, as of course people's risk. The idea of identifying high risk people is so you can bring their risk down. And so no, we didn't account for that, but it is something that would potentially impact the results. But at the same time, we do still see quite a number of cardiovascular cases, and so yeah, that's what we did. We didn't include it.
And then secondly, do you believe there is a trade-off between accuracy and fairness in these models, in particular with regards to the level of intervenable risk and not just elevated risk?
Yeah, I mean, so well, what we saw in the results was when we include the polygenic risk scores that it increases the performance, and the fairness is not decreased overall. And so therefore I would say that we don't really see this trade-off. Certainly not across everything, but again, it's hard to make like a generalization across everything. And so yeah, this fairness accuracy trade-off, I think is not necessarily true in all contexts. But in terms of whether it's sorry, what was the specifics about
In regards to the level of intervenable risk and not just elevated risk, I'm not sure I quite understand.
intervenable risk?
Chris, if you're in the chat, you can turn on your mic and expand a bit more on your question.
Yeah, is my AV working?
Yes, yeah, we can hear you.
Yeah, my question regards to because individuals can be at higher risk potentially for a disease such as cardiovascular disease, but there may not be a lot that you can actually do to intervene on that. So the capacity to actually reduce the risk may be quite low for some individuals versus others. I'm curious whether you think they're like sort of the incorporation of polygenic risk scores may affect kind of fairness distributions across that metric as opposed to just the level of risk.
Yeah, that's actually a good point, because I suppose with the polygenic scores, that's something that people can't change, right? Not like the other risk factors, which are much more modifiable by lifestyle or medication. Um, so I don't know if we can know from this kind of analysis, really, is what I would say. Yeah, because I suppose the idea is if you can find these people with the higher genetic risk, then you can decrease their risk by, if they know about this, then they can do other things that would reduce their risk, even though perhaps they have this high genetic risk. But then because they were also previously in the intermediate risk category, perhaps it means that there's more they can do. But I mean, I'm definitely not a clinician, and so it's hard for me to say exactly. But yeah, that would be my thoughts.
I appreciate that. Thank you.
Thanks.
Brew, why don't we go back to you?
Yeah, thank you. Maybe it's an interesting question on an intervenable risk, and it makes me wonder if there's any like studies that have looked at like whether the treatment effect or the treatment benefit from like statins like varies with your genetic profile, right? Because then that might point to it like not being a factor, or whether it's actually there's something with like absolute risk or relative risk. I don't know, but it's yeah, super interesting question. My question was going to be around like one slightly technical question, which is like I think I maybe missed how you compute the confidence intervals for the fairness metrics, and then another slightly technical one, which was when you do the nearest neighbor matching, does that mean you basically go to the smallest sized group for both? Because I wonder if you're like losing precision in your confidence intervals as a result of that. So like two linked questions there.
Okay, yeah, that's a good point. Okay, thanks. Yeah, the first one, so we do that, they're just 95% confidence intervals from bootstrap sampling. So we bootstrap the population. In this instance, it's 200 times. We see they stabilize after about 100. And then for the nearest neighbor matching, yes, we take the smallest population. So actually, so in ethnicity, for example, the white population is much larger than the rest. So we do, in that case, we look at non-white. So we match against non-white, and then each of the individual populations, and the others, they're much more comparable in terms of group size.
Okay, yeah, because I noticed for like for sex or gender, or I can't remember which one you had, like the like confidence intervals were like pretty small, but then they were
Yeah,
like much bigger for the ethnicity.
it definitely is related to that. I think, yeah, and because we don't have enough people basically in all the ethnicity groups in this data. So I
Yeah,
think that's why we see that. And so, yeah, in a different cohort, I think that we could get much more and much narrower confidence intervals, definitely.
yeah.
So
Another thing
then,
maybe permutation testing can be more powerful than
okay.
bootstrapping. In my experience anyway. So that might be like another thing to try, especially
Mm-hmm.
especially if you've got like permutation testing is very expensive if you've got loads and loads of samples. But in the
Mm-hmm.
smaller groups, it might lead to narrow intervals. I'm gonna follow up with one just like tiny suggestion because you're the
Yeah.
thing on the like on I guess you mentioned how you've got like loads and loads of graphs and like kind of communicating what those graphs
Mm-hmm.
mean in terms of fairness is difficult. And so I was kind of curious, and that kind of I think suggests like a broader problem in like the fairness literature,
Yeah.
which is it is really hard to interpret what like these fairness metrics mean in
Mm-hmm.
practice. And I saw that Vincent was here earlier, but I think he's left sadly because I think he had some nice plots which were kind of like these kind of like classic epidemiology plots where you have like number of people and you have like a grid of like 100 people and then you like you color in however many
Yeah.
people are like particular risk and then how many like are less at risk if they're given statins, for example. And I wonder if there's like some sort of like visualization like that in terms in the context of like fairness, which might also be like applicable in this context. But I've not seen anything like that.
That
It's
would
just
be
kind
great.
of like
I
a
don't
thought.
know.
But yeah,
I don't know how that would work though in the context of fairness. I'm just trying to, but
yeah, no,
that would be
just a
really
thought.
nice. Yeah.
I think it's like an interesting kind of like idea of how we kind of like communicate these types of
Absolutely.
findings in a more like understandable way. But no, it's super interesting. Thanks,
Yeah,
Claire.
I mean it's quantifiable, so I guess they definitely could be something on that. I'll look into it. Thanks. That's a good point.
Mm.
Yeah.
So thank you very much. We are out of time, but there are a few more questions in the chat. So I'd just like to say thank you to everyone for joining us, and you're free to go if you don't have any more time left. But Claire, maybe we could go through the last few
Yeah,
questions if you
absolutely.
still have time.
Yeah, sure. Why not?
So someone has asked on the limitation of intersectionality, what's your opinion and what do you see as the future work on that? Is it just that we need larger sample sizes or we need like a different data set that incorporates
Mhm.
I guess these groups?
Yeah, so actually, I was really keen to do intersectional analysis, and actually, I did try that. I tried to do it, and so I looked at basically the intersectional groups, which are the combination of the groups that I looked at here. So we'd look at like sex and ethnicity, or age and sex, etc. And the problem was that we don't have enough data. Basically, there's not enough individuals, especially some of them. Some of the groups become quite small, and then it means that the results that we get just don't really mean anything. Um, but I think it's something that really is very valuable because from even that analysis, I was seeing different patterns to what you see in the groups separately, and I think that's been it had been shown in the literature as well. And so I would definitely be keen to incorporate that, but it was a data limitation thing at the moment, and I think that that's the hardest thing about the intersectional analysis is having enough. Yeah.
Yeah, that makes sense. And then do you think polygenic risk score fairness assessment is tied to sensitivity, specificity versus overall accuracy? Um, so should we be judging only on their ability to reduce false negatives rather than looking at the true positive rate?
Well, I mean, yeah, again, well, that's based on the choice of metric as well. And so it depends on what you care most about. And so I'm not saying this is what you should only look at all. It's just in this context, I think we thought that it was most useful to try and look at the metrics that include about the um, false negatives, because we want to minimize those in this context, because we want to identify more potential people, especially because it's like a preventative context. So it's better to sort of overestimate, if that's the right word. And so that's why we chose these, but it's not that you should only look at that. I think it definitely can be, well, it is context dependent, and so there's more work that could be done there as well.
Okay, and then one last question. So Chantal says, well done in trying to unpack and unravel a complex, important issue. And that while you conclude it doesn't exacerbate fairness, what about the concern that it may perpetuate the baseline inequality that's already present?
Yeah, that's something that is not captured in this. And so that's definitely a very valid concern, something I've also thought about. But again, it is kind of, limits of what we have and what we know. And so that is much more difficult to quantify. And there's work going on in that space, but this work doesn't incorporate that. So yeah, it's a limitation.
Okay, well, that's all the questions. Thank you very much, Claire. I think this was a really great talk, and then lots
Okay,
of
thank you. I
discussion
hope that it
going
made
on.
sense, because it's kind of a lot to try and get
Yeah,
across.
no, definitely. It was really, really great. So thank you so much. And then thank you everyone for who's stuck around till the end. And then hopefully we'll see you guys. This was the last webinar of the year, so hopefully we'll see you all in the new year.
Yeah, thanks
Yeah,
again for
thank
the
you very much.
invite, and for everyone for listening.
All
And
right.
Happy New Year, I suppose.
Yeah.
Happy New
Thank
Year.
you.
Cheers, Claire. Thanks, everyone.
See you
Bye.
later.
Bye.
Bye.